Thank you very much.
Very clear.
Nice to see you, Sandhya.
Very nice to see you too.
Cue me. Cue.
Hi, everyone.
Hello.
Hi.
Hi.
Hello.
Looking forward to have a really productive discussion today. So
Same here.
I'll quickly, we have 1 minute to go. So I'll quickly say hi to everyone and then disappear.
Good morning, Jyoti.
Hi.
Good morning. Hi.
Hi, Jyoti.
So we're already almost on 4:30. Sorry.
Hello and welcome to this fifth webinar in the series organized by Development Alternatives. I'm your host or your moderator, Pankaj Pachori. So this is a series about literacy of women in India, which, as we've been discussing in the past, can add up to $770 billion. Yes, you heard it right. $770 billion to India's GDP. That is almost 1/3 of its GDP can be increased if Indian women were literate and they were participating in the country's growth and its uh, progress. So we have discussed how this can be achieved, and we've discussed about the financial inclusion, their participation in education, and women's participation in social life in India. We'll discuss later on gender politics of India. But today we are going to talk about something which is on the mind of each and every one of us. As India faces a momentous task of dealing with the second wave of coronavirus in the country, where more than 200,000 cases are being reported every day, India has become now the second largest country to be hit by the COVID pandemic. And the scenes on the streets in Delhi are absolutely bare because where we are talking from, because a curfew has been imposed now for a week by the local government as they grapple with this crisis. Health literacy becomes very critical and crucial. If health literacy in India was better, things would have been very different. Going by the data which has been gathered by Development Alternative, only 1 in 10 Indians is highly literate in health. And there are some more statistics we are going to show to you that how health can change the entire Indian scenario as we see it today. You look at it, education reduces the fertility rate of women by up to 10%, meaning the women overall have fewer children if they are literate and they know about their health much more. 1 in 50 women in developing countries tend to die due to pregnancy-related issues, most of whom are illiterate. And studies have shown that more than 44% of the children up to 4 years old had anemia because their mothers were not literate or didn't have enough health literacy. We have a very good and very knowledgeable panel today, and I welcome all of you in these times to at least come online, talk to us. It would have been a very good for us if we were all sitting, all of us are sitting in a room and talking to each other across our faces. We have Sandhya Venkateswaran with us, who's a fellow at Lancet. We have Michael Dobby, who joins us from New York. He is the executive director from Chitta Foundation from US. He's been working in India and Nepal. And we have Professor Santosh Mehrotra, who's been teaching at the Jawaharlal Nehru University, professor of economics, and also is a visiting professor at the Center for Development, University of Bath. We have Dr. K. Vijaya Lakshmi, who's the Vice President of Development Alternatives, and who will tell us that how their efforts, and particularly this particular effort with Tara Akshar, has been making women more health literate, and what have been the outcomes. We have Kanika Pal. Kanika Pal is South Asia Head, Community and Investments at Sustainability Programs of Hindustan Unilever Limited. She's very well traveled and works with the projects like Prabhat and Poshan Sathi, and she's been involved in WASH literacy. She's been a TEDx speaker, and we have Dr. Sunil Kaul, who's founder of ANT. That's Action Northeast Trust. He works in Assam, in remote areas of Assam, in Bodoland area, and he's trained about 200 bare feet doctors in that area. So he'll also talk about this thing. And we were supposed to be joined by Yasmin Haq, who's the UNICEF representative in India, but as you know, it's been a crisis and she's been called out for some other duties, but she sent us a message which we'll show during this program. So let's start from the top. Female literacy rate in India is about 70%, and we have range of 95% in Kerala to about 60% in Bihar. If we look at fertility rate, it's 2.2%, but the range is 1.7 in Kerala and 3.2 in Bihar. So we have just showed you some data, and we'll also going to show you some more data about that. But first, I'd like to go to Sandhya Venkateswaran because we've been discussing about COVID and coronavirus, and the importance of all the research which has been done and has been published by Lancet recently, and they are still under discussion. Sandhya, tell us, do you think that if women were more literate and they understood basic tenets of hygiene, do you think the situation would have been different in India today from what it is?
Thanks, Pankaj, and thank you to Development Alternatives for having me on this really important conversation. You know, there's much that's been written and researched about the link between education. I'm going to say education and not just literacy, because, you know, sometimes literacy is just, if you can sign your signature, you're seen to be literate. So let's call it education. So the link between education and health outcomes. you talked about COVID, but let me broaden this and say that if we were to look at, for example, NFHS data, and I'm sure Santosh will be able to talk about that, there's ample data and evidence in terms of the connect between education levels, women's education levels, and health seeking behaviors and access to health services, health promotion behaviors, right? What I would like to just focus on for a couple of minutes is that while we talk of education very broadly, it's important to unpack that in terms of, let's say, formal education, literacy, formal education, and health literacy. So, and simultaneously look at what are the pathways between education / literacy and health outcomes. Does education automatically translate into health outcomes, or are there other determinants that actually play an important role? And in that context, I would like to point out three broad areas. One is the role of what I refer to as health literacy, that a woman may be literate in terms of basic reading and writing, but if you are not familiar with health literacy, you don't know what the appropriate health seeking behaviors are, then it is not entirely clear what impact that is that education may or may not make to your health outcomes. So, just by way of what people refer to as human capital, the skills of information and knowledge play a very important role. So that's one. Second thing that I'd like to focus on is what we might call social or cultural capital, which is basically the skills of communications, the skills that lead to self-confidence status, which enable a woman to engage with a health provider. Because in the absence of being able to engage, one could argue that no amount of education or even health literacy would lead to better health outcomes. So that's the second one. The third one I'd like to point out to is empowerment, which is basically the building of agency that enables women to negotiate, to take action, to assert themselves and the decision that they make or would like to make. So these are sort of three determinants on the pathway between literacy and health outcomes, which suggest that the relationship between literacy and health may not necessarily be causal. There's a correlation, but there are other determinants. I think we're all aware on this panel that the normative culture in India is such that there is gender-based discrimination, because of which mobility is a question, women's decision-making ability comes under question. And until that is addressed, again, I'm tempted to say that the knowledge and the information that women have, they may not be able to put to use. So I'm going to just close initial remarks by saying that while education, basic literacy, health literacy is all very important, I think what we need to focus on is the relationship between people as citizens, as consumers, as patients, and the institutions that impact our health. And the two aspects here one is health literacy, and the second is the power that these institutions are willing to give women and the voice that they're willing to give women. Therefore, any intervention that we may come up with needs to take both of these into account. So let me just pause here.
That's really overall view on how health, literacy, education, they play a role in the conditions we are facing today. Because the basic thing about hygiene, what we are telling today people all over again at the national basis, that the Prime Minister of India and the government is telling people to wash their hands, which is a simple thing which was told to children by mothers in villages. Let's just broaden this and let's bring in some more data here of how literacy and health awareness is impacting women. If we can have some more slides here, all of you can see these and just bear with me for a second. Yes, that's it. This is key. Look at this data now. Now you're talking about literacy and education. This is a very simple correlation between education and women's behavior and the impact of it. Tobacco use among women who have not studied more than 5 years, who not got more than 5 years of education, schooling, is 20%, while in those who had more than 12 years of schooling is only 10%, half. The aware of tetanus, which causes a lot of deaths in during delivery or pregnancy-related deaths, is 84% among women who are less literate, and 92%, you can imagine, who are literate. Now, the whole idea of Indian family, if you look at it, and we keep talking about the population problem in India and that we have too many people, and now it's 2.2, which is okay. But if you look at it, women who have not gone to school more than 5 years think that 2.6 on average is a good number of a family, while those who just studied at the 12th standard, they want only 1.8 children. If you look at the postnatal care, 22% women, only 22% women who were schooled less than 5 years will go for postnatal care, while 31%. Next, if we look at it, health facilities and birth by schooling. This is a very key thing in India, where if you have no schooling, only 62% women were going for institutional deliveries. And if you had more than 12 years of schooling, you had 95% institutional deliveries among those women. And these are all NFHS data. You people are more aware of these than I am, but this is what I think I've culled out, and this you can see it. Now, the basic problem, what Sandhya was talking about, the status of women and in this whole society and their financial capabilities. If you look at this, exposure to mass media, 27% women have no exposure. 25% women have no exposure to mass media in our country. This is how, even if you say education beyond schooling, only 27% women read a newspaper once a week. They watch a lot of television, 71%. Radio is dying out, only 11%. And cinemas, the entertainment, 8.5%. But the most important thing here is that 25% of women have no regular exposure to mass media. And that tells us a lot about how women, how aware women are about health issues and how health literacy, when we talk about, can be spread unevenly in the society. We can go to Michael Dobby now in the US, who's been working in India. Michael Dobby, you would you like to say something in the beginning as your opening statement, or should I throw a question saying what has been your experience while working in Nepal and India vis-a-vis working in, say, Western country, US, for example?
Yes. Once again, thank you for having me here. It's a delight to see all these wonderful minds come together and discuss these issues. I came to this panel, into this idea of women and the strength that women can have in the society through kind of an organic process. I started with hospitals in rural areas and then went into schooling, general schooling. But I really found exactly what everyone's saying here is that over time, I really feel that women's education, understanding is the key to the families and the actual transformation of communities. And it seems to be one of the things that in most cultures are lacking the most. So it's kind of this weird dichotomy. So I've worked in near Mount Kailash in a lot of rural areas with the Mayans in Mexico and Guatemala, in Orissa. So I have a good cross experience with different cultures, the ways they compensate for not having information. Like India has a wonderful tradition of, say, Ayurvedic herbs and remedies or treatments, but a lot of people, they don't even have access to their own education, so they make up things based on superstition, ideas, and social stigmas. So, I mean, and with the Mayans in Mexico, there was women, when they had some pregnancy issues, they would put pig's feces around their eyes, and they felt like somehow that was going to, I mean, it was a disaster, but it's somehow they felt that that was going to bring them through it. And I've seen in Orissa, women taking their children to tantras because of the lack of access to healthcare or information, like you're saying, like media or any other ideas. So I think this newest project I have coming up in Rajasthan, in Jaisalmer, it's the culmination of all these experiences that are going to focus on women, girls' education, and the empowerment of women. And the Tara Akshar, like the program seems amazing because it's bringing this element, I think that's the most important, is accessing the women who basically run the family from within, and they're lacking confidence, they're lacking engagement in their communities on a level that makes decisions for their families. They're lacking that information, but I feel like they're thirsty for it. If you give them this information and talk, we can see the progress that's happened in places like cooperatives in Gujarat or different parts of the country where you give women that information and safety and ability to speak up, and they really do kind of pull things together and take control. But then again, in India, I find that any family has any means or has any money coming in, the first thing they do is take the girl out of education or take her out of the workforce, or it seems to be a prestigious thing. So I think the idea of accessing women in the families is really the most powerful way to transform the communities.
Yeah,
in terms of healthcare. Yeah,
that's absolutely right, because this whole the correlation between economy, growth, and women's health literacy it's connected. You mentioned Rajasthan. I worked in Rajasthan in an area where there were practice of female infanticide, and the village I found had no girl children at all, and they had no road as well. They had a school, but they had no road which connected them to the outside world. So this correlation between economy, between growth, development, and status of women, that has been studied a lot in Uttar Pradesh, one of the problem states in India, and by Professor Mehrotra, who joins us. Professor Mehrotra, tell us about your experience in working in the hinterland on how improvement of literacy, education, and health literacy, top of it all, can really help. Number one, to integrate women in as a force in the nation building, and number two, to improve our rural areas. Your mic is.
Yeah. I just realized that. Thanks very much indeed.
Thank you.
To Development Alternatives and to you, Pankaj, for inviting me on this. Actually, the broad issue that you've raised has rather well been addressed by both Michael and Sandhya. So if you don't mind, as perhaps the only economist on this panel, I'm going to sort of address the issue of how health and literacy, not health literacy, but health and education impact economic growth. Now, on this, I've actually done some solid number crunching for India by state. And I'm going to give you very briefly what emerges from this model that I've developed. And this is published in international journals. So I'm just going to tell you what the results are from that. And then perhaps in another round, I can come back to the sort of issue which I was asked to address by Development Alternatives. So we look at data from the early 90s to 2018 for every Indian state, and we look at which states sustain GDP growth and which states do not. So which ones have high growth and which ones have relatively lower growth, and which ones sustain growth and which do not. And something very striking comes out. And I'm going to just tell you 2 or 3 results. You don't have the time to go into more than that. So the first thing that comes out is something that some of you may know of and others may not, is that the states with sustained high growth, which we are defining as over 5% per annum, were in fact also those who were relatively advanced in their human development index, meaning in their human development outcome indicators. And what are these states? The very expected ones. It's sort of Kerala, Tamil Nadu, Karnataka in the south. There's Delhi, Punjab, Haryana in the north. And in the west, there's Gujarat and Maharashtra. I mean, these are the states which had invested a considerable share of their GSDP on both health and on education relative to the other set of states, which I'm now going to name, which we all know again, they're relatively backward in terms of their HDI rankings. And what we essentially discover is that HDI actually impacts economic growth. That's the point I'm really making here. That the UP, the Rajasthan, Jharkhand, Chhattisgarh, Bihar, Madhya Pradesh, Odisha, they have registered well below 5% growth, and they also have higher incidence of poverty, and they have higher infant mortality rates. So you may say, okay, we are looking at a stylized fact of correlation, but then we actually run this econometrically and do this very, very carefully. And what we find is positive and statistically significant coefficients for the mean years of schooling, which is what I think we are really interested in here. And why am I saying mean years of schooling? Because we know that in our country, it's the girls who've been left out. And in recent years, we know that the girls have done rather well. It's a subject that I will come back to. But what's important is that the mean in the states which have sustained growth are the ones which have seen a much higher improvement in the mean years of schooling. And this is exactly what one would expect. So clearly, you know, that's result number 2. I'm being again very schematic here and very brief. And there's a very clear relationship also, of course, which Sandhya and you were also talking about, which is that relationship between mean years of schooling and IMR. So we find that relationship in the high-performing states, which were not only fast-growing, but they also improved their human development indicators. And we do, you know, very sophisticated tests, not just Granger causality. We go beyond that, and so on. And one final thing on this before I close. It's a model which looks at not just health and education on the one hand and growth on the other, and the mutual interaction between them. It also brings in poverty. What happens to income poverty? And we find that there is a bidirectional causality between poverty and IMR, and between poverty and mean years of schooling. In other words, if we want to make an argument to a minister of finance in UP or Bihar, that look, put your money in health and education because it will increase your growth and it will sustain your growth. So in other words, you know, ministers of finance don't see value in putting money in health and education, particularly because they feel, you know, the results are going to show up in 5 years' time. So this is an argument both to Nirmala Sitharaman, but also to the Minister of Finance in UP, Bihar, Rajasthan.
Yeah,
let me pause there.
That is very simple because, you know, our policy makers, all the finance ministers, they see health as a cost center. They don't. They see health as a cost center and not as an investment center. The minute we start thinking of health as an investment center, and it's for everyone to see that neonatal mortality rate in Tamil Nadu is 11, while in Uttar Pradesh it's 30. Now, it's very simple. And this is where efforts like Tara Akshar become very crucial, because you go down, you put some boots on the ground, and you go down on the ground, and then you start building bottom up. And that's why these kind of programs, we are very happy as Go News that to partner with Tara Akshar on this. And because this is good education. Most of our people who watch our digital news are in villages now, and it's very good that they get to know uh, uh, what is important and what is not important. So we can go now to Dr. K. Vijaya Lakshmi, who is the Vice President of Development Alternatives, uh, to tell us that how Tara Akshar has worked in this particular area
Yeah.
and what have been demonstrable outcomes.
Thank you, Dr. Pachori, and thanks to all the panelists for gracing the occasion to share your thoughts and enhance our own collective learning and also the audience and moving towards better India. I think Tara Akshar was born out of a need of development alternatives, working on increasing the enhancing the life for quality and livelihoods of India, especially working in the Vimaru states, which are the most poverty-ridden states. And there we realized whatever we are doing as technological interventions or holistic interventions, the basic thing that was missing was India is still having 186 million population not literate. Then you can do the gender gradations and age, all that. And over in the last 5 years or so, we have improved in terms of the literacy rates, especially the gender gap is reduced with the young population, girls coming into education. But we have a backlog of 186 million people not educated, means the entire intergenerational aspects. People who are not literate are unable to take part actively in the development of the country. So that is where I think we started looking at what are the tools in which we can educate and literate, especially those women who are actually bringing up the children in a family, responsible for families, the entire economic growth, and what are those ways in which we can bring in this program. And there was a technological innovation that has happened in terms of pedagogy. And also we apply this IT-enabled tools like we use the desktop or laptop to teach the women in the rural areas. And highly trained manpower has been created. And we are touching base across 8 states. And women, as many as 200 to lakhs of women in the size of the each batch of first two we are touching upon. And this program, particularly the Tara Akshar, is a result of coming out with this pedagogy in terms of memory hooks. So we created this entire package of how we can make a person who was not even know how to even read, write, recognize, or even able to speak, can be made literate, not only in terms of reading, writing, communicating, but also able to understand through those pictures and audiovisual media her entire being, her own existence. And how do we empower this? I think that is where the whole program of Tara Akshar started. And we are fortunate to have some of the young, old colleagues who made this possible. And it's running like a real excellent program. And the Wall Street Journal has acclaimed Tara Akshar program as one of the fastest and most powerful program across in the world. Only limitation we have is it is currently running in Hindi. In all Hindi languages, we are able to touch upon. And because of only development alternatives efforts and our partners' efforts and our people like IKEA, institutions like IKEA Foundation, various other funding sources that we have, UNICEF, we managed to reach out to more than 235,000 in the last 1 decade. Thanks to all those funding support that we got. Also, not just the funding, but they have invested in us in terms of understanding the whole program impact. So we managed to identify what are the kind of changes we can bring to make the program so powerful that, so the learnings that we have, I agree completely with the Sandhya's and Dr. Santosh's observations. Like when we talk about education, it's the basic literacy that is important for a woman to, especially the woman, why we are talking women is, they are the economic backbone of the country. We are missing that $776 million dollars loss to the country in terms of economic power is not, we are not having those women in the economic cycle. So how do we make sure that that happens? So the basic part is to make sure that the woman comes out with confident, her attitude and practices change about her own body. So we combine three programs. One is the basic literacy, which can happen in 56 days. And we designed it in such a way that the woman takes out time, 2 days in an hour, 2 hours in a day, about 56 days over a period of 3 months. We complete the basic skilling in terms of understanding, memorizing the basic, basically reading and writing. Following to that, we continue to have another program combined to that is Gyan Chaupali, which is again a program of educating the person on various aspects of life skills and also health literacy. And third program is once we have an empowered woman in terms of who's actually started building her own confidence, started gaining respect in the family because she is now literate. Now the next step is to empower her with financially. So the financial literacy program, health literacy program are the backbones of Tara Akshar. So just not literacy, but to take her to the next step where she can come out not only from the house in to contribute to the family and to the society. All these three elements are coming together. In the last 1 decade, we managed to reach that. And when we did at least twice in the last 10 years, we have a very intensive impact assessment study that was done. And the figures show that the Tara Akshar literates, when you go and survey a control group and Tara Akshar literates, there is a marked difference in terms of how the whole chain of things, there is a chain reaction that happens. Basically, the woman who is literate in Tara Akshar decides for herself, or is able to decide for herself when she wants to have the baby, when she can do the, how she can raise the babies, and she accessing the health facilities, and also able to negotiate her rights. So all these things, through collective learning, it is happening. So we surveyed, and the numbers speak for themselves. In Tara Akshar villages in UP, Uttarakhand, we found at least 70 to 80% people, Tara Akshar village, the village program people have at least 70% of them are able to answer how they are handling the latest example being Corona. And they learned how to communicate. They learned how to do the hand washing, not only for their family, for themselves, but also able to convince the local communities and taking the extra burden of going out into the communities, educating everybody. And these are the changes unheard of. Once they used to be in the gungat, the gungat means they are in the parda. They used to use the veils. Now they are coming out. So that much of confidence, the self-esteem has gone up. And this is unheard of and unimaginable just by giving the literacy.
Thanks.
Thank you.
Thanks for your statement, and thanks for telling us and taking through that what kind of impact you can see um, once the program is over and what the outcomes are. One big thing, and I'll come back to that, is opportunity cost, $770 billion, and how to scale up efforts like Tara Akshar. I can go to now Kanika Pal, who's been working on such programs, which is one of them is a volunteer-based program called Swachhata Doot. Now, this is what we've been talking about, how to keep hygiene. She's been working with the nutritional program, Poshan Sati. with Unilever. And with a company like Unilever, which has been quite involved in social responsibility efforts. Kanika, now the government thinks that this is a cost center. How the corporates can, think ahead and turn it into some sort of investment center when it comes to imparting basic knowledge to women.
Thanks, Pankaj, and thanks, DA team, for having me here. With such erudite speakers speaking before me and giving perspectives from the field to the economic perspective, I think I very rightly, what I want to do is focus a lot on this word, Pankaj, that you've used, investment. And the reason why I say that is because actually any penny that you spend in the community can reap unprecedented benefits for the nation, simply because a country like ours is primarily agrarian. We are economically backed by a rural hinterland, and they continue to remain extremely unrepresented even in debates like these. How wonderful would it be if this debate would have somebody from the rural India speaking about what literacy means to that person, what health literacy means to that person. And I would dare to actually perhaps represent some of the learnings that we've had through the work that we do at HUL. So, before I get started, I just want to spend a minute to make a demarcation between literacy and health literacy. And the reason of why I want to do that is because we have people in the audience who perhaps need further simplification of what we are really trying to drive home as a message. So essentially, we are all dealing with COVID, and right now the second wave is so bad that every one of us in our families know somebody or the other who's right now dealing with COVID as we speak. It's not a third person's problem. It's something that's reached home. So imagine if your family is unwell and then somebody needs to administer medication, but you cannot read the prescription. You cannot read the instructions on the medicine bottle. Worse still, you cannot Google search on the availability of best practitioners around you or the health information around you. Can you imagine? That is what happens when a person is illiterate. We know what illiteracy is, but we don't necessarily actively imagine what it translates to when we are talking of it in our day-to-day language. So basically, illiteracy prevents people from being able to simply be in charge of their health and health outcomes. What that also means is that they are unlikely to have information and timely information on communicable diseases, on diseases like AIDS, malaria, and now COVID-19 and other infectious diseases, right? Now, we've all seen a lot of statistics that has already been shared by you, Pankaj, but essentially 2/3 of the people who are illiterate continue to be women and girls. And mind you, these are the people who, when there is a health adversity in the family, are taking care of the sick people. They are carrying the burden of sick members in the family. So automatically, when these people are illiterate and they are the care providers in the family, that means two things. One is they are less likely to know about prevention and support services and how to make use of these services and treatments. And second is this exacerbates health inequity, in the overall larger sense, which means that health and life expectancy of people like poor people, elderly people, gets pushed far behind. Right? These 2 points are very, very important, because clearly that means that the moment you're improving literacy of our population, and women and girls in particular, you're doing two things. One is that you're making it more equitable from a health perspective, and second is therefore poor people are likely to be more healthy on nutrition, hygiene, and would demand more health infrastructure in an overall sense. Now, I just want to very quickly take another 30 seconds and talk about health literacy. Health literacy essentially would mean that this is not just about reading and listening, but also having analytical skills and decision-making skills. for your own health outcomes in a health situation. So basically, it means that you're providing agency that can be exercised by a woman, by a girl, for her to take decisions for herself, for her family, and therefore for the larger community, right? So it's not just about reading prescriptions. It's not just about reading what the drug really means. It's really being able to negotiate across the complex healthcare system for better health decisions on the whole. Now, coming to corporates and what corporates can do, and why in HUL we look at community investments as community investments and not corporate social responsibility. The program that I head is called Prabhat, which is a holistic sustainable community development initiative. And the two parts of it under health initiative that you spoke about, Swachhata Doot is our largest employee volunteering program, where our people go into the community and teach simple habits of hygiene and hand washing. And DA has also partnered with us in this endeavor in our initial stages. And the second program is Prabhat Poshan Sathi, which essentially is, as the name suggests, buddying the woman in her nutrition journey, especially with a focus on pregnant and lactating women. So a cadre of women reach out to, they are trained on nutrition, and they reach out to, larger women folk in our rural hinterland on providing them with basic information on nutrition. And they work and align a lot more closely with the ASHAs and the ANM workers. Having reached out to just within a year to almost 300 villages in 3 districts across 3 states through a network of 100 Poshan Sathis, the learning that we've had from these almost 1 lakh women who we've advocated to is that the moment you're providing more literacy, health literacy, nutrition literacy, there is a behavior change that gets triggered. Yeah. So we have seen that iron folic acid tablets demand in a state of UP, for example, has increased because the decision making of the woman on the ground changed due to more nutritional literacy being provided to her by the Poshan Sathi. Another very important example that I want to share with everyone is that, in one of the engagements of the Poshan Sathi, the rural woman wanted to undergo a sterilization surgery. She had no idea that there's something known as vasectomy, which is possible. And the moment she became aware of it, and the Poshan Sathi further connected her to the ANM, along with her husband, she used her agency, decided that, it will be the husband who will go through the procedure rather than her. And the husband in 2020, January, had a very successful surgery. So essentially, health literacy is definitely empowering women if it is done from an investment lens rather than a cost burden.
Yeah, but
and finally,
please go ahead.
Yeah, no, so I'm just making my closing remarks, Pankaj, really. And just on some of the statistics that you showed with Tamil Nadu compared to UP, I completely corroborate with that. The places where literacy is more, education is more, even early initiation of breastfeeding, we've seen that those indicators are far higher, rather almost double, compared to states where literacy and education on the whole is lesser. And therefore, through our work, we have enough data to prove that within a year, we've seen 9% increase of early initiation of breastfeeding happening just because there was health and nutrition literacy that went ahead. So I'm just going to close here and give, top 3 points where our learnings have come in. We need to understand the cultural context of every state if we want literacy and health literacy to improve, and therefore this to become an investment. Second is that a life cycle approach needs to come about, which means that you need to start early, you need to start young. Behavior change cannot happen and will be very tough when you start much later. And third and last point is that localization, local language, and simplification of information is really the key for health outcomes to be far better than what it is today. I'd stop here, Pankaj.
Thank you. And what Kanika has been talking about hinterland and talking about the rural areas, talking about almost zero literacy areas. We have someone who's done that and who's been there, Dr. Sunil Kaul, who's founder trustee of AND, which is Action Northeast Trust, and he's worked with some of the people who live in very remote areas, and have been able to train I would say battalion of bare feet doctors in those areas. And tell us, Dr. Kaul, we know the problem. We know all this problem. What kind of problems you are facing when you go there and you want to put all these great ideas in practice? You are on mute, sir.
Thank you so much, Pankaj, and DA as well. Good to hear. I think most of the things have been said. I just want to highlight certain things. One, that this evidence that health outcomes, I mean, which are usually comprehensively, we say that if you want to measure health, you should look at infant mortality. And the evidence that infant mortality is affected the maximum by a single factor of mother's education up to the 8th standard has been there for 20 years. It's just that we in the cities or in the power-making echelons, we wake up too late. So I'm happy that Tara Akshara is happening, that we are kind of focusing on this. That it's a known devil which has been there. If we were to, and you showed some data about 12 years and above, if the education was meaningful, probably we could have achieved it in 8 years, what probably is happening in Bangladesh and in Nepal and South Africa and many other places. Unfortunately, probably in India, you are seeing the stark differences only after 12 years. Two, I think, we talk about literacy in such a sense, but when we talk about high female literacy, we invariably talk about Kerala. We forget about Mizoram in the Northeast.
Yes. Right? Yes.
And so
Tamil Nadu take all the credit, yeah.
Yeah, so and it's not just that female literacy does not happen because somebody invested in literacy, because the society believed in some amount of female equality there, and that's why that happened. And I also, why I'm trying to highlight this is, if you want better health outcomes, it's not just the literacy, because if you go to Manipur, which is next door, the female literacy has been, and both, I mean, male and female literacy had been very low, but because women had a better sense of power in society, their infant mortality was lesser than most of the Bimaru states all through history, right? So it's, when we are talking about literacy and learning, and I mean, not just education, I would say learning. So people don't learn only from, the Akshar Gyan. It's also about how, the icons or how things are happening around them. And I'm just trying to highlight why we chose women as potential change makers for health. Of course, that was at the time when there was no NRHM, there was no health facilities in Assam. And at that time, we chose this because also we wanted to show that women can be the agents of change and they should be the agents of change. Two is that I think as a society, we are also, I think rural, women, and illiterate. We tend to exploit these three separately as columns, I would say. And if we could just remove the illiteracy, at least a rural woman would be probably, she'll save herself from more exploitation. And I'm telling you that most of our nurses and most of our ashas, they are some of the most exploited even in the health system. So as iconography, we are actually continuing their exploitation and we're not showing a very healthy position to people who are looking at health. So health, again, when you look at it, it needs much more investment in women, I would say, not just in literacy. I would like to see them as agents of change. So in many, many ways, we need to change that so that this health outcomes, which has been a given for last 20, 25 years, I'm saying that there's been enough literature or development literature, science literature, or health. Last but not the least, I think we're still very confused sometimes when we talk about health. We still talk about absence of disease, whereas we as health people understand health in a much, much more exalted fashion or at much higher levels. And I remember when I was doing a parallel session in a large women's conclave, for rural women. And then I was asking the simple question of what do you think is health? And I'll never forget what a woman told me. And she said, to me, sir, I mean, while, some of them had already learned how to talk about the definition, she said that if I can laugh, if I can play, if I can work, or even if I can weep whenever I want to. It's that sense of agency, that autonomy. When I want to, for me, that's health. I want that health. So it's not this absence of disease. It's fulfilling the autonomy and the choices of that person. And so in that sense, if you look at, we need much more investment in women itself. Education is just one of them. And I would say if education has to be meaningful till the 8th standard, where I would say at least basic health can be achieved, the quality of that elementary education, and I'm just saying this from experience, that our 8th standard, science education till the 8th standard also needs to be ratcheted up, so that women who reach that stage, at least, because if we want to do something fast, we will be able to do much more if our science education had improved. Yeah, I'll just leave it at my opening.
That's very heartening to hear from you, that someone who's been working in very adverse circumstances still has so much hope, and that's what we are living on. Because the kind of mountain we see ahead of us, 115 million women in our rural areas who are not even educated beyond 5th standard or something. I mean, that's really, and to be hopeful in that, and that hope will live on. And as you talked about health and education, the education of health, I mean, I keep coming back to it. We are having this discussion in a very somber sort of time, when we have a major pandemic breaking out once again within a year. And the education on health is through this pandemic, because people for the first time are now realizing that washing their hands can save their lives and the lives of their near and dear ones. And people are telling children not to go out, or not to touch surfaces. So that's what it takes. When we talk about literacy, there are lots of alternative education which is there. Wedding songs, if we can turn wedding songs into health songs, it will be wonderful to see that. And a lot of people who are doing this. And I've been waiting for Yasin Ali Haq to join us, but we have been told that she is being called to a meeting. You can understand what's going on in the country, and she can't be with us, but her office sent us a message from her to all of us. So we'll just play that from Yasin Ali Haq, who's the India representative of UNICEF.
The COVID-19 pandemic has impacted the well-being of children everywhere. Nearly every aspect of a child's life has been put on hold.
Now, what's a webinar
The
where
COVID-19 The COVID-19 pandemic has impacted the well-being of children everywhere. Nearly every aspect of a child's life has been put on hold, and we face the threat of decades of progress being rolled back. A year-long learning crisis has ensued from the school closures, and there isn't enough access to digital means for remote learning. Malnutrition among mothers and children has likely been exacerbated due to the economic and livelihood crises that families are coping with. Children's safety has become of a concern, with escalating reports of violence and abuse throughout the year. The pandemic has underscored the critical role of resilient social protection and health systems, of digital connectivity, and public-private partnerships. In these challenging circumstances, millions of health and frontline workers have become our beacon of hope and our inspiration. We would like to thank millions of teachers, parents, caregivers who are doing their utmost to support children in learning. we still need to watch our distance, wash our hands, and wear our masks.
This is what health literacy is all about. Wash your hands, watch your distance, and wear your mask. And it's come down to this after millions of lives lost across the world and here in India, where it's not abating. Dr. Mehrotra, I'll come to you now and tell us whatever you heard in the discussion so far and what Yasmin Haq was saying there. Do you think that we are actually equipped ideologically and mentally to deal with what we are working towards? I know it's a very large question, large canvas, but I'll really hope you can give us some. Yeah, you are on mute. You are on mute.
I'm going to home in very quickly. I'm going to say only two things, even though you're asking a large question. So let me, are we prepared? I don't think we are prepared. Let me explain what I mean. Because unfortunately, the experience with this government has been that in the last 6 years, the finance minister has actually kept expenditure on health and on education flat in real terms over a 6 to 7 year period, while expenditures on vote catching items has grown and grown and grown. Now, clearly, we are already paying the price of this in the following sense, that although we made a commitment in our national health policy in January 2017, that we're going to raise our public expenditure to 2.5% of GDP by 2025. And the Finance Commission, the 15th Finance Commission, which just submitted its report 3 months ago, said we have to increase allocations. What have we seen in this budget? We have not seen an increase even in this budget. All we've seen is an allocation of 35,000 crores for the COVID vaccine. I mean, we had to spend on the COVID vaccine. We had no choice in the matter. If under these situations, the government is not willing to increase public expenditure, then I don't know under what conditions it is going to do that. This is particularly tragic, and this is my second point. Our women are much better prepared to receive the kind of information that I think all our panelists have been speaking about. What do I mean by that? I mean two things here. One, and I don't think we recognize enough the role of Sarv Shiksha Abhiyan and of the midday meal scheme, which has actually enabled our girls in particular to complete 8 years of education. And remarkably, between the years 2010 and 2015, the secondary enrollment, right? We've been talking about the importance of higher secondary. Well, secondary enrollment jumped in our country from 58% to 85%. And that happened with gender parity. It happened with gender parity. I don't think this is sufficiently recognized. At our level of per capita income, it's very unusual for a country to achieve gender parity in secondary education, which suggests that these girls are actually ready for much greater health literacy. And they're also ready to take up jobs in the labor market. But the jobs are not growing because growth is not happening. And which takes us back again to our health and education expenditures. Because you've cut off health and education expenditures. You don't want to invest there. So our growth has slowed. And what we've seen is this divergence happening between the North and the South, which I was talking about, from about the mid-1990s. This happened in this divergence increased very sharply in our country because of this difference between the one set of states and the other set of states in the allocation to health and education. So we are a tragedy. It's a real tragedy here.
This very sobering note there by Professor of Economics, which is quite, thoughtful intervention there. But is throwing money at a problem like this is a panacea? That's one thing. And Michael Dobby, I'd like to ask you on that. What has been the experience of other countries on this? If you throw a lot of money on women education and in rural health infrastructure, do you think that is the only way out of this? Or can we build it brick by brick as Tarakshar is trying to do?
I find that, well, now that, there's numerous reports on this, that the inclusion of women, the education and inclusion of women in a society anywhere in the world increases the stability of the country and the productivity of a country tenfold. I mean, it's I don't know, like, I think we've known this for years, and I've seen it in several parts of the world where you give the women nutritional information, financial literacy, basic education, and financial opportunities, like they'll build the family very quickly. And I think I've seen this in many remote areas of the world. And the thing we're dealing with is, like I said earlier, was a lot of lack of information women have, superstition, general misunderstandings. But what I think we're all talking about here is that women are very receptive to take care of basically the role in all these different cultures is to take care of the family, nutrition, organizing, making it stable. And the men are in a lot of these remote areas, a lot of basic protection or working outside of the family. So access to women and giving them that, I've seen this really change the places I've worked. And that's why my final project is focusing solely on a protective environment for girls' education and women, giving them economic opportunities, and reaching out to the families through the ASHA and different workers in the villages to help reduce this female infanticide rate that you were speaking of earlier, and make it give an environment for the women there, and just really see if all these statistics we're talking about put into action in a place as difficult as rural Jaisalmer in the Thar Desert region. Those women face some of the worst obstacles I've seen in many countries, and really see if this is, I feel it's going to make a big difference, and hopefully it could represent what could happen in all these different regions.
Yeah. Oh, okay. Thanks about that. We're now getting questions from people who are watching the webcast, not just here on the Zoom call, but on Go News platforms. There's a question for Kanika. Why the company's CSR is usually restricted to the areas near their geographies? Do businesses always look for ROI in terms of growing business? And Poshan Sati seems to be a very interesting program. Do you use a lot of technology? Kanika.
Okay, so yeah, thanks, Pankaj, and whoever asked that question, thanks for that. And I think, ROI, impact assessments, now these concepts are also mandated under the CSR law. So, let me just talk about what was not there before the law. And as scientifically designing interventions, I think it's a good practice to understand every rupee which is being invested in community, is it leading to an impact for them? What more value is it generating for them? Yeah, so ROI does not mean it's a return on investment for the funder. It's a return on investment for the community. So that scientific knowledge is so important for good programs to be developed and long-term impact to be envisaged and realized through some of these programs. The second part of the question, Pankaj, is on technology. And I think through Poshan Saathi program also, and also a lot of work that under Prabhat that we do on livelihood, yes, technology is a very important lever, because while disseminating information, forget COVID for a second, even generally, using phones, using tablets, using, caller services, these are such important tools to reach out to the community. And digital empowerment of the woman, just as we are talking of financial empowerment, health empowerment, is an equally important trigger for her to be able to make much more informed decisions for herself, as just being a woman who's leading a healthy lifestyle or having a more fulfilling life. So yes, digital is very important.
Yes, yeah, and the ROI in digital is very clear, that if I look at the base of women using smartphones in rural India, like about 18-20%, and if it's available to them, they'll use it more, they'll get more information. And we've discussed this in our last webinar at detail, and how that can actually, be a very good way of corporates actually to increase their base. And once technology reaches there, once information reaches there, then all kind of goods reach there. Those goods, that knowledge women use, they become entrepreneurs, and
Absolutely.
that's how all the boats rise. This is what
Pankaj, can I just add one small point to this as well,
see.
Which I think will be very relevant. We all see in another program for dairy farmers, we realize, which is again digitally empowered, it's not necessary that a woman has a smartphone. The son, the daughter, or the man of the house may have a smartphone. But the moment you're delivering a message to the woman through the smartphone or on a smartphone, she will start making use of the technology. So accessibility of technology available in the house is also what programs enable.
Yeah, absolutely. I mean, cooperative smartphones, I think it's a good idea. We should think about it. That family smartphones, cooperative smartphones. I'll go back to Dr. Kaul also. Where in all this, and we keep reading about it in terms of the pandemic, that people's mental health is not now in order, in terms of, there's a large scale impact of the pandemic on mental health. Where all this fits in, because once we are on one hand, we are talking about basic hygiene, we are talking about safe deliveries, we are talking about keeping your hands clean. Is it how do we reach, and how did you reach an area where you are talking in villages about mental health? You need to unmute yourself, doctor.
Yeah, sorry. I think the last 1 year has been quite tough. Last 1.5 years, I would say. And because on the mental health of women, especially because I think in India, as we say, the men build houses and the women make them homes. And so the whole family is revolving around the woman, and she takes care with all her, I think, sacrifice that she has to make culturally for keeping this home together. And the NNA, the NRC, the CA, which hit us, and then the pandemic. I think for all that, I think a woman has been bearing the load of it. And we've had a mental illness program for a long time. And we have been reaching out to women. When we started, as you were saying, we had a lot of women health workers whom we had got, barefoot doctors, and then many of them became Ashas. So we continued our relationship with Ashas, and these Ashas have been taking our message through to other communities. But just the women itself, I mean, we've also been working with women on especially mental health, because we recognize that mental health of women is also very central to continuing. I mean, as somebody was saying about a life care approach, I think if you look at the life of a family, The woman is very central to it, and the mental health, her mental health also is a very important thing. She's the caregiver of the mentally ill people also. So I think in a nutshell, as I said earlier, if you want to invest in women, I mean, the rest all follows suit. I mean, if we can just develop the idioms in which we can talk to women, the language in which she can understand, we have to break it down into bites which they can understand. We will be able to get through. I think because, knowing how barefoot doctors, we created barefoot doctors, they could they could not just pronounce chlorpheniramine or paracetamol or the doxycyclines. They could even remember the doses and give them correctly. So it's not difficult. It's the only thing is, are you investing enough in terms of time, resources, today, the digital literacy, all that, and you definitely can reach out to the women and talk to them both about mental illness or any kind of illness. Do we believe in them? Do we believe in giving them an agency? And hence, do we empower them? I think all that, I think we build them not just as one component, but as I said, using women just for the iconography that a woman can do it, it makes a ripple effect all around. And, making her empowered to speak chlorpheniramine or, a mental illness thing builds her leadership capability, builds her this thing. So all that follows suit. So it's not just one, as I would see it.
That's yeah, absolutely right, and everyone will agree with you on the panel on that. Sandhya, I just wanted to ask you one question which has been bothering me a lot. How can we, and bothering all of us a lot, how can we say use this pandemic to focus attention on this very important issue? That if, research wise, are there any research available, or are there some research being done on this, that if we had a better literacy among women, a better health literacy among our population, the impact of this pandemic would have been different and lesser?
So, Pankaj, I would say that there's a lot of research that's been done over the last several years, as Dr. Kaul pointed out as well. And I think a couple of things that the pandemic has surfaced in very tangible ways underlines a lot of what we are discussing. So, for example, just building on the mental health issue that we were discussing, much has been written and discussed about violence against women in the pandemic, right? Because, everybody was in some ways trapped at home, if I can use that word. How often do we look at the correlation between violence and health, right? It's such an important issue, but nobody looks at it. We talk of agency, we talk of empowerment, and yet this is something that our health system, it doesn't figure anywhere in. Even, I'm tempted to say, even if a woman has all the education and the health literacy, if she's being beaten up at home, would she really be able to go and access a health service? I think that's a debatable question, right? So this is one issue. The other issue that's got surfaced in the pandemic is resources. Santosh talked about this, touched upon it. I think a lot of us were shocked that this was the one time that the health budget should have been increased. We expected it to be increased, and yet nothing happened. There was hope that there would be some reforms that would be announced, but none of that happened. I think this is a great opportunity to look at, I would say, the convergence of a lot of sectors. Even now, we've been talking of health, education, we've been talking of women, but when we look at our policy environment, these are still very much in silos, right? There's a separate department or ministry that looks at education, a separate one for health and a separate one for education. And I'm tempted to say, never shall they meet. So how do we actually look at this as, from a client perspective, if I can use that terrible word client, from a person's perspective, rather than our sectors and our ministries and our departments? That is something I feel pandemic has taught us, because it was a health disaster. It turned into a social disaster with the migrants. It's turned into an economic disaster at a macroeconomic level. It has increased poverty levels. So it's turned into an economic disaster for individuals. We need to bring it all together. So I think now more than ever is a need to look at all these issues in totality, because we know that they are very, very strongly interrelated.
That's the finding opportunity in a crisis, and this is exactly what should happen.
Pankaj, can I just join? Can I just add here a 30-second thing? Yeah. We work against domestic violence, and I see it as a public health issue.
It is.
It's the first 1,000 days of life, which are not just important for nutrition, but even for the learning, even emotional learning, social adjustments, all the maximum takes place in the first 1,000 days of life, from the time the child is conceived in the uterus to the first 2 years. And we feel that, a constant demeaning of women, beating up in front of the child perpetuates her, this inferior feeling, the lack of confidence in herself, her learning. And I think we need to tackle it as a health issue, domestic violence, not just the faster we can do it, because you're very right, Sandhya, that during the pandemic, we had an epidemic of domestic violence as well. And I think this is the time to get all of this together.
Pankaj, if you don't mind, can I come in with just
yes, please,
very briefly a couple of points? I'm going to confine my remarks to women's empowerment. You see, very interesting survey was done by the Nandi Foundation in 2018 of teenage girls, 13 to 19-year-olds, 70,000 across 20 states. And something very interesting came out. A question was asked to these girls, at what age would you like to marry? Now, you and I know that the legal age for marriage for girls is 18. 26% of them said we want to marry between the ages of 18 and 20, and over 50% said we want to marry between 20 and 25.
Wow.
That's 3/4 of these teenage girls saying that we want to marry well after the legal marriage age. Now, the question then arises, what is their aspiration? What do they want to do? They've all gotten educated. And their obvious aspiration is that they don't want to be in agriculture. Their mothers are leaving agriculture. Their fathers don't want to be in agriculture. They certainly don't want to be in agriculture. And they don't even want to do Zari Zardoshi and bidi making. So they want to get an urban job, but jobs have to grow, for which you require growth. Point one. My second point, which I found was very heartwarming, because we've been sort of talking about such, depressing things in this webinar. But when I was looking at the NFHS 2019-20 data for women's empowerment for the 13 states, I was, very pleasantly surprised on this question. I remember looking at the second NFHS, 98-99, where a similar question was asked, and it was so depressing that most women could not, regardless of which part of the country we're talking about, most women could not take an independent, autonomous decision about healthcare and going to see a health provider. And it's interesting that whether you're talking about Andhra or you talk about Bihar, the currently married women who usually participate in 3 household decisions, and those 3 household decisions are: one, decisions about healthcare for herself; second, making major household purchases; and third is visits to family or relatives. The interesting thing is that between even 2015-16 and 19-20, between the 4th and the 5th, in Andhra, you get an increase from 80% saying they have the right to take these 3 decisions. And in 19-20, that has increased to 83-84%. And I'm going to now very quickly just jump to Bihar. And Bihar, the same question, 75% in 15-16 were saying they can take that decision. And 84% were saying this in 19-20, which suggests that, increasingly this education is having an impact. It's showing, that means the readiness of these women for resisting the violence.
The norm, yeah.
Exactly. And taking these decisions. If only the state would act at this juncture. If only.
Yes, and it's not just to the state. This pressure from below finally it changes the policy. It changes your minimum age for marriage. It changes school education curricula. It will change these things, and this pressure has to come. And this pressure will come not by the kind of education we are talking about, the literacy, going to school. It can come also by our social education. And most of people tell me that most of the education these days is being done in Haryana by women people, and they are the main now icons who become in Haryana, which has a very terrible gender politics and gender imbalance. Going away from this, we are very close to our end, and looking ahead for an opportunity. When we talk about the pandemic, we talk about the opportunity. The opportunity is being harvested by pharmaceutical companies. Michael Dovey, if you look at the S&P pharma index, it's gone up by 36% in a year. Everyone who's invested in big pharma companies is laughing away to the bank. How can we then change this from going to pharma companies? How can we create a new sort of a module where people will start investing in girls' education instead of in a pharma company? Because the ROI could be the same, not in a year, but in 10 years down the line.
But then the pharmaceuticals won't be making the money they're making. I
think they make more money because more women are educated, more women are earning. I mean, naturally, the consumption of pharmaceuticals will go up.
Yes, yes, and that you've touched on it's a big issue, especially rural India. The understanding of healthcare, pharmaceutical use, the way doctors impart medicines on having hospitals in rural areas. I deal with this a lot, and women are usually very low end of the totem pole because they lack any kind of agency or understanding, and they just listen to the doctors. They tend to prescribe a lot of medicines, so it's not really. It would be a big benefit to educate the women on basic healthcare and not just.
My question is not that, Michael. Sorry, my question is that can we have this issue of enabling women with education and health education, I mean, attractive enough that more what we call foreign direct comes here along with the pharma sector?
Yeah. Well, I think that would be an obvious, like we all know that would have benefits, but I wonder if there's a way to actually incorporate that into the pharmaceutical companies' agenda, or the way they actually confront these programs in rural areas or healthcare faced by women. There's I think well, it's a difficult question because a lot of these companies or programs are based on their own investments and their own profits, and like oil companies. I mean, alternative energies we know are a great way to go, but it's like, how are you going to convince them? So, but I think keeping the what we're all doing here and what we're all agents for in these regions is to show that it does make a difference, and to get we're democracies, so that if everyone understands what's actually happening in these regions when you empower women and you provide more information for their own healthcare understanding and for their own bodies, you see that difference. And I think that'll put pressure on larger companies and peoples, but it's hard for them to think that investment's going to give them what they're getting within their company. But I think it's obvious what happens. So hopefully a lot of the data we collect, a lot of the actuals that when we engage these rural cultures and peoples and we see these outcomes, hopefully that changes the mindset in the same way that we're seeing with alternative energy sources and things. I think we know it's obvious, but there has to be ways we bring it to the companies. I think the companies, I don't know if they would make that like jump.
We need a climate change. We need a climate change or something of that order to get this thing. Dr. Vijayalakshmi, I was about to come to you.
Yeah, I just want to, this is very interesting debate that is happening. I think we got the answers, but they're all in jigsaw puzzle. I think what we need to do is what Sandhya said, we need to have contextualized investments going based on the local needs of the people. So if the woman has to be empowered, so what we need is a blended investments, both from the government and the corporate sector to come together and invest in those places to ensure that the SDG goals, start with the SDG goal of women empowerment, economic empowerment, literacy becomes the starting point, literacy to self-reliance, do whatever is needed to bring that, and then you start looking at other goals being met over a period of time by empowering. So this requires collaborative action among various sectors, while everybody gains, both government agenda fulfills and the corporate agenda fulfills. Now the corporates are more and more looking at ESG returns. They are now, their stock exchange indicators are not anymore shareholder values, but I think it is more towards return on investment in terms of environment, social goals. I think this is the right opportune time for us to garner strengths. We know the answers, but we are not putting the puzzle together and make sure those investments look at the entire SDG goals. We need to invest in food systems, not just the hand wash, but I think the alarming report I read, the Kerala and those high literate states now going backwards in terms of child marriages and obesity is growing. So these are latest trends. We need to address these issues more systemically, and going back to so we may be going into a trap right now, though we have earned the highest literacy, highest levels of those indicators we talked about, may go back if we don't address the fundamentals of how we are trying to grow.
Thank you. That's exactly the kind of upbeat mood I wanted to end this discussion on, that we have to stop looking this the health and the education sector, health of women, education of women as a cost center, but as an opportunity center and also in terms of attracting investment from the government, from the corporate, from public-minded the citizens, the HNIs. That's where it lies. And as you said, our researchers like Sandhya, like you, are the corporates like Kanika, are the people on the ground like Michael and Sunil, and the people who are sitting and doing all the number crunching, the economists like Dr. Mehrotra. We all have to come together and evolve some sort of a new module where people can invest. And where you can invest, you can join the Development Alternative campaign, Tara Akshar, and you can donate, you can volunteer your time, and you can take this forward. And believe you me, these are the only ways by which we are going to go forward on this very important issue. Thank you, all of you, very much. It's been a very difficult but very illuminating discussion. Difficult because of the circumstances under which this is held. And I hope, and like all of you, that things will become better. Thank you very much. Goodbye. We'll be back 2 weeks later.
Thank you.
Thank you.
Thank you all. Very nice.